Good morning, everybody. If we're all set, I would like to open this academic ceremony, during which Maria Abbattista will defend her academic thesis titled Venous Thromboembolism in Women, a focus on unusual sites, pregnancy, and thrombophilia. Before we start the actual opposition, we will have about 15 minutes for the candidate to present a summary of the study and of the conclusions. Please.
Good morning. I share my presentation. Good morning, everyone. Dear Prorector, dear members of the Corona, and dear audience, thank you to attend to my PhD dissertation. In the next 15 minutes, I will briefly summarize the results of my research on venous thromboembolism in women. Starting from the definition of venous thromboembolism, or VTE, it is a medical condition caused by the presence of a blood clot in the lumen vessels. VTE has an annual incidence of 1 to 2 per 1,000 person year, and it nearly affects 10 million individuals every year worldwide. Therefore, it is considered the third most common cardiovascular disease after myocardial infarction and stroke. We know that male sex is a risk factor for the recurrence of VTE, but we observed similar incidence between sex for the first event of VTE. One study hypothesized that this difference between sex could be masked by the presence of female exposure to reproductive risk factors such as oral contraceptive use or pregnancy. Indeed, they were able to show that men were at a twofold increased risk of VTE compared to women without reproductive risk factor, while women were at the highest with the reproductive risk factor had the highest risk of VTE. Among manifestations of VTE, the deep vein thrombosis at the lower limbs and the pulmonary embolism are the most common. But we know that VTE can affect any venous system. So rarely it can occur at unusual sites that include cerebral veins and sinuses, splanchnic veins. It can occur at the upper limbs in the renal, ovarian, and retinal veins. And we know that sex could also modulate the presentation and the manifestation of VTE. Indeed, we recognize some female-specific sites, like the ovarian vein thrombosis, and other unusual sites that are more involved in women, more frequent in women than in men, like the cerebral vein thrombosis. The cerebral venous circulation includes the cerebral veins and the dural venous sinuses. Among the latter, the superior sagittal and the transverse sinuses are the most frequently involved. However, in the 2/3 of cases of CVT, more than one sinus is involved. Cerebral vein thrombosis is a rare disease with an annual incidence that varying between 2 to 15 cases per million person. And it typically affects young adults with a female to male sex ratio of 3 to 1. So it is 3 times more common in female than in men due to the specific female risk factor. VTE, both at common and at unusual sites, is a multifactorial disease that develops as the result of 3 major components: vessel injury, venous stasis, and hypercoagulability, historically known as the Virchow's triad. And we recognize several risk factors that predispose to VTE, contributing at least to one of these 3 major components. Among risk factors, we distinguish inherited, also known as thrombophilia abnormalities, which include the most common gain-of-function mutations, factor V Leiden and prothrombin mutation, and the rare loss-of-function mutation, protein C, protein S, and antithrombin deficiencies. And among acquired risk factors, we recognize surgery, immobilization, older age, cancer, just to name a few. And when it comes to women, as anticipated, we recognize reproductive risk factors such as oral contraceptive use, that increase the risk of VTE by 2 to 6-fold, and pregnancy or puerperium that are associated with an increased risk of 5 to 10-fold. Then the concomitant presence of such reproductive risk factors and thrombophilia abnormalities led to a multiplicative effect on the risk of VTE. So to deepen the knowledge on the oral contraceptive use as a risk factor for VTE, we performed a case control study on a large population of women of childbearing age, and we observed that the risk of VTE was highest in women who were short users within the first year of use, first users, and were aged less than 30 years. This risk was not observed in the long user, was decreased in long user, and this trend was not observed in women aged more than 30 years. Moreover, we observe a strong interaction between the presence of thrombophilia abnormalities and the oral contraceptive use, particularly in the first year of use. Also, pregnancy as a female risk factor is recognized because pregnancy is a unique condition that has all the three components of the Virchow's triad. And despite the hemodynamic and hemostatic changes induced by pregnancy are physiological, they can put the women at risk of VTE during pregnancy. Indeed, we observe pregnancy-related VTE incidence of 1 to 2 every 1,000 pregnancies. Moreover, this risk could also influenced by the presence of other additional maternal risk factors, such as the previous VTE, particularly if the previous event was unprovoked or hormone-related, and the presence of thrombophilia abnormalities that is usually identified with a prevalence of 50% of the pregnancy-related VTE. Moreover, thrombophilia abnormalities, other than increase the risk of venous thromboembolism, could also increase the risk of obstetrical complications, possibly as a result of an impaired placental circulation. And among the obstetrical complications, we should recognize and distinguish those that occur in the first trimester, such as the early miscarriages, from those that occur afterward, that are placenta-mediated and include preeclampsia, eclampsia, HELLP syndrome, intrauterine growth restriction, small for gestational age newborn, placental abruption, and stillbirth. So, supposing a shared mechanism between thrombosis and obstetrical complication due to an impaired circulation in the placenta, it was believed that the use of heparin could also prevent from obstetrical complication, but its efficacy is still uncertain. So with this background, we want to evaluate whether or not women with a previous CVT were at increased risk of pregnancy-related VTE and obstetrical complication, and what was the role of heparin prophylaxis during pregnancy. So to approach to these questions, we performed 2 observational studies on women with a previous cerebral vein thrombosis, while on heparin prophylaxis during pregnancy, and we observed no recurrent VTE, no bleeding, but a 6-fold increased risk of late obstetrical complication compared to healthy controls. This risk was not associated with any history of obstetrical complication or comorbidities, and it seems not to be influenced by the presence of thrombophilia abnormalities. However, we observed a higher prevalence of termination, voluntary abortion, in those women who were thrombophilia positive compared to those who were thrombophilia negative. Then we selected a subgroup of patients to perform a case crossover design, patients who had both pregnancy before the CVT and after the thrombotic event. And we observed that after the thrombotic event, women appeared at increased risk of late obstetrical complications. These figures remained similar in a subsequent study where we slightly enlarged the cohort of women, and we performed also a case crossover design, and we were able to observe an increased risk of termination after the thrombotic event. Then we changed setting and we evaluated the risk of pregnancy-related VTE and obstetrical complication in a cohort of women with the rare and severe inherited type 1 antithrombin deficiency. That is the most severe thrombophilia abnormalities because it is most thrombogenic. And we observed that there is a high risk of pregnancy-related VTE, both in pregnancies conducted with heparin prophylaxis than in those conducted without, with an overall risk reduction of pregnancy-related VTE of 40% associated with the use of heparin. Moreover, we also observed a nearly 5% of VTE during pregnancy in those women who are believed to be at the lowest risk of pregnancy-related VTE, such as women without a previous history of VTE and with a negative family history of VTE. So at variance with the guidelines, we suggest the use of heparin even in this subgroup of women. Regarding the obstetrical complication, we observed an increased risk of late obstetrical complication despite the use of heparin prophylaxis, particularly in women without a previous VTE, and termination were significantly more frequent in women with a previous VTE than in those without. In the last observational study, we evaluated the first pregnancy after VTE, after the most common manifestation of VTE, and we observed no recurrences in pregnancies conducted with heparin prophylaxis and a 14% recurrence in those pregnancies conducted without. Almost all the women who recurred during pregnancy had a previous hormone-related event associated with the oral contraceptive use on pregnancy. Also, heparin appeared to reduce the risk of miscarriages, but not that of late obstetrical complications. And women with thrombophilia abnormalities decided for termination even in this setting twice more than those without. So, in conclusion, the risk of VTE associated with oral contraceptive use is highest within the first year of use, particularly in first users aged less than 30 years. And this risk strongly interacts with the presence of thrombophilia. Women with a previous cerebral vein thrombosis, while on heparin prophylaxis during pregnancy, are at low risk of recurrences during pregnancies, but appear at increased risk of late obstetrical complications. Women with a rare and severe type 1 antithrombin deficiency are at high risk of both pregnancy-related VTE and late obstetrical complications, despite the heparin prophylaxis. And finally, carriers of thrombophilia abnormalities with a personal history of VTE, both at common or at unusual sites, are more inclined to terminate their pregnancy. This brings me to my last slide, where I would like to thank all the people of the Angelo Bianchi Bonomi Hemophilia and Thrombosis Center in Milan. And in particularly, I would like to thank my colleagues and co-authors, Dr. Artoni, Bucciarelli, Capecchi, Ciavarella, Giagnello, and a special thanks to my supervisors that supported me in this path, Dr. Mattinelli, Professor Mannucci, and our director, Professor Flora Pivandi. And thank you all for your attention.
Thank you for this very clear presentation. The opposition will now be opened by Professor Kroon. He is a professor of vascular medicine at Maastricht University, and he was the chair of the assessment committee of the manuscript. Professor Kroon.
Thank you, Pro-Rector. First, I want to congratulate you with this beautiful thesis. I read it from the beginning to the end, and I learned a lot. I want to start or I want to extend, of course, my congratulations to the supervisors, both in Italy and the Netherlands, of course. I'm sorry, I forgot that. But now my questioning. I want to start with a question on chapter 2. You wrote a nice literature review on treatment of unusual thrombotic manifestations, and that's been published already in Blood in 2020. And in most cases you describe there, you recommend to start with low molecular weight heparin and followed by vitamin K antagonist in the acute phase. And I was wondering whether that was still accurate. So I went through the literature, and of course I came up with the advice that sometimes also in the acute phase, a DOAC, a direct oral anticoagulant, is started. Have you, after this publication in 2020, and now there is a lot of new information in the literature, do you have reason to revise that advice of starting low molecular weight heparin and vitamin K antagonist in the acute phase?
Well, to date, the mainstay of therapy remained the anticoagulation, starting with the heparin, because the alternative with the DOAC is something that is still off label, we could say, because for the unusual sites, the unusual sites were not included in the registrative trials of DOAC, and even for DOAC we need to use heparin, not for all four, but we need to use heparin before starting actually with the DOAC therapy. So to date we have just one study, I think, that was already published, that is the Respect CVT, where they used the dabigatran versus and compared the dabigatran versus warfarin, and they showed that there was a similar recanalization after 6 months of therapy. So the only data available right now are few, did not allow us to change what we suggested in this review at the moment. I think that in the next future some other studies will come up, and because there is even the Riva SVT that was.
But what makes an unusual site thrombotic event so special? Because when we have a deep venous thrombosis in the lower leg, we start with a DOAC.
Well, the difference could be the presence of concomitant disease, and in particular for cerebral vein thrombosis, splanchnic vein thrombosis, even the deterioration and the presence of bleeding in the cerebral system could be a problem different to the deep vein thrombosis at the lower limbs. So for the unusual sites, there are other conditions to consider. Do
you think it's because of it's oftenly associated with cancer?
Possibly, but not only cancer. Because, for example, in the cerebral venous system, we could have severe patients with a cerebral hemorrhage, even without cancer.
Well, okay. With respect to time, and I want to have more or less the same question for DOACs, but now with respect to the chronic situation. In chapter 3, you wrote a beautiful narrative review again on cerebral venous sinus thrombosis, and that was published in 2018. And if you allowed me, well, you didn't, but I did. I went through the literature and found meta-analysis, a very recent meta-analysis published in 2022 in, where was it, in the Acta Neurological Scandinavia. And they summarized that in the chronic phase, a DOAC would have the similar, so it was a meta-analysis, would have the similar efficacy as a vitamin K antagonist, and even resulted in a better recanalization. So do you think your advice has to be revised in the chronic situation?
Yes, even if the answer is not for sure, I just guess that the use of DOAC due to their easy use and more manageable use in the chronic phase in particular, they will for sure an alternative approach because they could lead to an easy management for the patient with a long-term therapy. So it is possible that in light of the new data provided from the meta-analysis and the study on the real-world experience from some center, yes, they could change this.
But I hear a bit of hesitation. Do you think there is a problem with the DOAC? Do you think it might, well, you miss the adherence to the drug, or that you are a bit hesitative in answering this question with a real yes, DOAC should be started in?
No, I think it's just something that depends on the experience. So more experience we have, and more we could be safe using an alternative approach. So DOAC are available from 2013. So
okay.
We are not so much experience, especially for the unusual sites. They are rare.
Okay. Well, my last question, if I'm allowed, yes, thank you, is concerning the testing for inherited thrombophilia and antiphospholipid syndrome. If we would have a case of, let's say, a cerebral venous thrombosis in an obese woman who is taking oral contraceptives, do you think we have to go for testing in these cases, or is your opinion, because I couldn't find your real opinion, you wrote something in the summary and general discussion, but I want to taste more of your kidneys on that. When do we need to do testing for inherited thrombophilias? Well,
this is a debated issue, because the thrombophilia screening is something that one should want to do in a massive way, but this could be the best way to approach to this problem. So I think that it is important to have an individual assessment of the risk of the women we are counseling for the oral contraceptive prescription. So for the example suggested, it depends. If the women have a previous history of VTE, if the woman was young, or has a family history of VTE.
But so, I describe a case, sorry to interrupt, I describe a case of oral contraceptives. 80% of oral contraceptives are the cause of cerebral venous thrombosis, and that is increased by 5 or 6 times when you're obese. So why should you test?
Well, maybe this will not necessarily will not be necessary to test for thrombophilia in a patient who had no previous event or a negative family history. We just can choose the best way to...
When it's a recurrent event, I think you're right, but
yes.
then we should test. But generally speaking, do we need testing in obvious cases?
In obvious cases, maybe yes. In a very young patient, yes.
Okay, well, thank you for your answering, and I'll
it could help for the therapy afterwards.
Director. Thank you very much.
Thank you.
Thank you, Professor Krohn. The opposition will now be continued by Professor Eichinger. She is a professor at the Department of Medicine of the University of Vienna. Professor Eichinger.
Good morning, Mrs. Abbattista. I'm very honored to be part of this Defensio, and I really enjoyed reading your thesis. It was very interesting, and from the beginning until the end covered a lot of relevant issues related to women's health, and also, of course, coagulation. So I immediately switch to chapter 7. Chapter 7, this is dedicated to your study on antithrombin deficiency. It's the chapter related to the retrospective single center cohort study you performed together with your colleagues. And the results of your study show that there is a high risk, or a fairly high risk, of thrombotic events in women with antithrombin deficiency, and not only for the recurrent thrombosis, but also for first thrombosis. And of course, we do have standard thromboprophylactic regimens, and maybe we can discuss a little bit the thromboprophylactic regimens we now apply in women who are at risk of thrombosis. And so do you think that what we are currently recommending needs to be revised? It's not enough? Shall we expand it? Shall we select women on a different basis? Because what you found is not only relevant for women with antithrombin deficiency, but it's also relevant for other women who are at risk of thrombosis.
Highly esteemed opponent, thank you for your congratulations. And yes, we found something unusual or surprising, because we know that the guidelines, for example, suggest to wait and watch women with antithrombin deficiency during pregnancy, for example, when they had no previous history of VTE or a negative family history. But we observed a high risk of pregnancy-related VTE in those women. So maybe we should revise some suggestion for the heparin prophylaxis approach in these women.
So you are now talking about the antenatal period, so before delivery.
Yes.
So what you suggested is that we should also put these women on thromboprophylaxis when they have a diagnosed antithrombin deficiency, even without a history of thrombosis.
Yes.
What about the postpartum period in these women?
Even in the postpartum, that we know it is the period the highest risk of thrombosis. So it is important, because the guidelines suggest in the several situations to approach just with the prophylaxis just in the postpartum period. So we maybe should extend this prophylaxis even to antenatal period, obviously in the postpartum.
And you use the standard dose of low molecular weight heparin, like in the order of about 4,000 units once daily. So we do have data that even if women use this kind of thromboprophylaxis, there are still some who have a higher risk of recurrence. Yes. Should we adapt the dose? Should we? Because you also found that this might prevent recurrent thrombosis, but you did not observe an effect of thromboprophylaxis with regard to pregnancy complications. So should we probably change the concept completely by adding
something else,
aspirin or something like that?
Well, there is not a correct answer to these questions because we don't know. Actually, we don't know what is the best way to approach to these women. For sure, we observed women with prophylactic dose that recurred during pregnancy, and even women with the therapeutic dose because they were on therapeutic doses before getting pregnant. So even in these women, we observe an high risk of recurrences. So maybe we should think on alternatives. For example, the use of antithrombin concentrate. That is something that we could use, but we don't know actually how to use it because there is no a standard for the use of antithrombin concentrate. So we should think on the possible alternatives because there are a subgroup of women at high risk during pregnancy, even when they receive the heparin prophylaxis. So we are missing something here, I think.
Okay, yeah, we could go on and on and on about these questions, but I will make use of my time and ask another question, a different one. So I would like to go back to your chapter 2, where you intensively studied and evaluated all the different aspects related to cerebral vein thrombosis. And in your studies and also in other studies, there is always this association between cerebral vein thrombosis and the prothrombin mutation. And this observation, I am not aware that you find this association also with other thrombotic sites. So why is there this association between particularly the prothrombin mutation, particularly cerebral vein thrombosis, particularly in women? Is this something pathophysiological? Is this something epidemiological?
Yes, this is an interesting point, an interesting questions that I would like to answer with some certainties, but the pathophysiological mechanism of the cerebral vein thrombosis is not fully understood. And why this occurred more frequently in women, why this is associated with oral contraceptive and pregnancies, and why there is the prothrombin mutation more frequent in this case, we actually don't know. I think that we should further investigate the hormone-related mechanism. In my opinion, that could be the additional information that we could have, and because we know that CVT develops in association, in a strong association with oral contraceptive use and pregnancy, and both are hormone-related situation, and both underline an estrogen-induced mechanism. So maybe there is some link between this estrogen-induced mechanism and the prothrombin. Maybe it's something there. We know that, for example, some transcriptional mechanisms are modified by the presence of estrogen. So maybe we should investigate further this issue.
Yeah, that's certainly, you have certainly a point there, because we still do not know enough about how these hormones truly affect the hemostatic system, so that because they not only increase the risk for cerebral vein thrombosis, but also for other thrombotic sites, and we definitely need to do more work there. How about the time?
You're done.
I'm done. Thank you very much.
Thank you. The opposition will now be continued by Dr. Klok. He's from the Department of Medicine, Thrombosis and Hemostasis at Leiden University Medical Center. Dr. Klok.
Thank you, Mr. Rector. Madam Candidate, I would like to start with complimenting you and your supervisors with this beautiful thesis. It consists all of chapters that are relevant to our day-to-day clinical practice. It was a pleasure to read. If you allow me, I'd like to discuss a bit more details of chapter 8, in which you describe a cohort study of fertile women referred to a dedicated thrombosis center for thrombophilia workup, and you studied the impact of the use of low-molecular weight heparin on pregnancy outcomes and concluded that low-molecular weight heparin during pregnancy appears to be effective and safe for the prevention of recurrent VTE as well as miscarriage. In the discussion section, you mentioned that the retrospective study design was a limitation of your study because it may have introduced recall bias. I, of course, agree, but wonder what other impacts this retrospective design may have had on the presented results. And in particular, I cannot fully appreciate from table 1 if the hospital protocol you described for the yes or no low-molecular weight heparin and the dose of the low-molecular weight heparin was always followed. And in table 1, there are 10 patients with severe thrombophilia abnormalities. They did not receive any low-molecular weight heparin. And I wonder whether this may have affected your outcomes if those patients actually would have had received heparin. So could you please elaborate on the decisions that were made in the individual patients and whether if those patients would have been treated too, your conclusion may have been different?
Opponent, thank you for your compliments and for your question. Well, you asked me for the table 1, correct?
Correct.
Yeah, so the difference among pregnancies conducted with and without heparin. And yes, this could be related to the fact that we collect data from patients who were already referred to our center, and we focus on the first pregnancy after VTE. So the pregnancies who were conducted without heparin maybe were managed not under our management. That's why we have these differences. And maybe, yes, if they received heparin during the first pregnancy, the thing will be different. And so this is one of the problem of the retrospective design, because when you did not start from the beginning and follow your patients in a systematic way, you can have some drawbacks, something on what you can do nothing to ameliorate. And so
Yes,
this is.
I do agree with you, but I would wonder if you could speculate on what if those 10 patients would have received thromboprophylaxis. Would then possibly your conclusion had been different?
From the pregnancy-related VTE point of view, possibly exactly. Yes. I think definitely yes, because we know that women with thrombophilia abnormalities deserved, with a previous thrombotic event, deserved a thromboprophylaxis during pregnancies, both antenatal and in the postpartum puerperium period. So definitely yes, I think.
So would you? So I think you are sharing with us that then probably it would have been let's say a negative result. So then there would have been no difference in the rate of VTEs because you would have prevented the VTEs that actually occurred in the other group. So that's I think it's very important to realize that that's also when you read retrospective studies, it may be because of selection, because of these kind of decisions in the treatment, the outcome can be very much skewed and very difficult to interpret. Thank you for agreeing with that. The next question, also for this chapter, would be the preeclampsia. PE is a devastating complication of pregnancy caused by placental hypoxia and ischemia, and it may be prevented by antithrombotic therapy, especially aspirin. In your study, it was very interesting to see that the incidence of preeclampsia was higher in those women who received low molecular weight heparin compared to the ones who did not. Can you give an explanation for this? Do you understand how this may have occurred?
Thank you for this point, for your question. It is a very relevant question, and I think that we should do more on the pathophysiological mechanism of obstetrical complication, because we hypothesize that there is something shared between the thrombotic event and the obstetrical complication. But all the data reported in this thesis point towards something else. There is something else that leads to the preeclampsia, for example, complication, and the other obstetrical complication, particularly late and placenta-mediated. Because in my opinion, there are other variables that we don't include in our evaluation of these women. For example, the hypertension.
And do you think that low molecular weight heparin causes preeclampsia because it was an excess of these events in the women who were treated?
Well, I thought about it, honestly, but it is something I don't know. I don't think that it could have a causal role for the preeclampsia. As I said, there are other variables that heparin does not have an effect on these other variables. So it seems that could be a causal factor for something, but I don't think this.
And if you would look at this point, this question with regard to the design of your study, perhaps then it can be possibly explained without blaming the low molecular weight heparin.
For the design, sorry, I didn't understand the question.
No. So I'd like to go back a little bit to the retrospective design and the dangers of retrospective studies. Can you come to a reason that this design may have caused the fact that we see more preeclampsia?
Yes, possibly. Possibly, yes. It is the design a design problem more than a real causal factor. For example, even in the study of the pregnancy after CVT, we observed the same increased risk of late obstetrical complication after the thrombotic event. But in that period after the thrombotic event, there are two variables. One was the cerebral vein thrombosis, and the other one is the low molecular weight heparin. So it's difficult to say that which one of these two are the most important causal role. Possibly the thrombosis, because we know that the low molecular weight heparin in other settings is different. So yes, it depends from the design.
And could it be that the fact that the patient had thrombophilia developed a thrombotic event and thus was treated with low molecular weight heparin was the cause of the eclampsia rather than the treatment itself? So the fact that they have thrombophilia may be associated with the preeclampsia, which is then the confounder in what you've seen in your thesis?
Could you answer that question with a yes or a no, please?
Depends, but sometimes yes.
Thank you very much.
Thank you. The opposition will now be continued by Professor Spaanderman. He is a professor of transmural obstetrics and gynecology at Maastricht University, and he is the secretary to today's ceremony.
Thank you, Mr. Prorector. Dear candidate, congratulations with the finalization of your clear and concise thesis. I've read it with great pleasure and interest. And I also want to pass these congratulations to your supervising team, obviously. The thesis predominantly regards women with internal difficulties and conditions amongst pregnancy. So this is the population I primarily take care of. So you can imagine my professional interest. I like to move over to chapter 4 in your thesis. For a starter, I like surprises, but only when they are nice. And when I prescribe oral contraceptives, that makes me also responsible for the health of the woman that I prescribe the thing for. So I want to anticipate on side effects, and thrombosis is one of them. And the thrombotic risk is incredibly high in your young early starter population with thrombophilia. But I never see you stating that we should test these women up front. So what is withholding you or us in not screening these women before we endanger their health? Can you comment on that?
Yes. Highly esteemed opponent, thank you for your congratulations. And thank you for your relevant questions that I, in part, anticipated. And yes, I will comment on that because we observed a high risk of thrombotic event in association with the oral contraceptive use and thrombophilia abnormalities. But the massive screening in the women population, in my opinion, will not be so in favor of the prevention of the risk, because we know that the prevalence of thrombophilia in the general population is low. So it is varying between 1 to 5% for the different mutations. So if we went to a massive approach, we could generate a workload, an excessive workload, and we could generate a waiting time for the exam, for the prescription of the oral contraception. So maybe it is not the best way to approach to these women. And I think that the most important thing to do when we counseling women for the oral contraceptive prescription is to evaluate the personal, the individual risk based on the family history, the personal history, and the other concomitant risk factor, and select those women who can benefit from a thrombophilia screening in a very precise way.
Yeah, I can imagine that, but even when you correct for a BMI, and Professor Kroon was already addressing the BMI issue, but even when you correct for that, the risk of short users with thrombophilia on getting deep venous thrombosis or even worse is 62. Suppose I'm at the outpatient clinic, you as a woman want a prescription for oral contraceptive, and I tell you, okay, I'm not sure, but by giving you this medication, your risk will be at least 7-fold on thrombosis in the upcoming year. But when you have thrombophilia, let's say that's 1 in 20, then your risk will be 62-fold as compared to don't take it.
Yes, it's too much, but we should acknowledge that this the risk reported it's not generalizable on all the prescription, all the oral contraceptive. So we should take into account even the type of oral contraceptive, the route of administration, So these figures could vary according to the different oral contraceptive, and we know that we could choose some prescription at lower risk of VTE. So we should evaluate even the type and the route of administration. Yeah. So we could say not that the risk is 62, but
it is in a way. That's
in
what
a
you
way,
were telling
yes,
us.
for the third generation pill, in particular in this case.
Yeah. So, suppose thrombophilic screening only would cost €5. Mm-hmm. Would that then change your opinion in this?
Maybe in some particular occasion, like the women who were obese, maybe yes, but we should take into account the other and other aspects of this information, because we demonstrated in this thesis that knowing that being carriers of thrombophilia is something that affects the life of women at the time of diagnosis, possibly, and even afterwards during other situations at risk, like pregnancy. So it's not something that should be done in an easy way, because I think that one of the main points highlighted from this thesis is the psychological impact of this knowledge, particularly in the pregnancy after the thrombotic event. So we should be aware that an information of a genetic condition had an impact that could be traumatic for some women. So
that is what is withholding you. So in a way, you agree with Professor Kroon. Just look and then advise something. Okay. I have an eye on the time. Mr. Prorector, can I ask another question, or is my time done?
Very brief. It's a very brief question with a very brief answer.
Okay. Then I have a very short question. Hyperhomocystinemia. You're addressing that as a thrombophilic disorder, but the treatment is quite different than low molecular weight heparins, and yet you add them with the thrombophilic disorders. Can you comment on that? Really short.
Yes, we know that the level of homocystinemia can be corrected with the folic acid. So, and we know that this is a weak risk factor for VTE. So we acknowledge in the list of the possible thrombophilia abnormalities, but in the most of the analysis of this thesis, then we don't include the hyperhomocystinemia in the analysis.
Okay, I'm happy with your answer, and I give the word back to the prorector. Thank you.
Thank you. The opposition will now be continued by Dr. ten Kate. She is an associate professor of medicine at Maastricht University.
Thank you. Dear candidate, of course, as the last one in the row, I would also like to congratulate you on your thesis and the work that you've done. I'd like to include Professor Manucci and Professor Martinelli and Professor ten Kate in this. But I'd like to add something else. I'd really like your cover. It's really Dutch. It gives us a little touch of spring. So with that, I'd like to continue with the opposition and exchange thoughts with you. And it's a little bit in extension to what Professor Spaanderman already discussed with you. And before we start this, I'd like you to ask you to read proposition number 3 for us.
Yes. The duration of oral contraceptive use influences the risk of venous thromboembolism in young women, median age 25 years, but not in older ones, median age 40 years. And the risk of venous thromboembolism associated with the duration of oral contraceptive use strongly interacts with the presence of thrombophilia abnormalities.
Thank you. Well, if you read this, you make a strong discrimination between women younger than 30 and women older. And I do not really understand this. Could you explain why this would be? Why would a woman of younger than 30 have higher risk?
Yes, esteemed opponent, thank you for your congratulations. And yes, I would like to speculate a little bit on this, because we don't exactly know why younger women could have an increased risk than the older ones. But I think on that, and I imagine that the possibility that the estrogen-induced mechanism had a different impact during the year, because there are some data that show that the estrogen could affect the gene transcription. And so maybe, and we know that the transcriptional mechanism varying between the over the years through the epigenetic mechanism. So it is possible. It is possible.
I would not go into this really difficult explanation, and would look for a more simple explanation, maybe. I'd like you to go with me to page 63, and there you have this study design, and there I see that pregnancy-related VTE is excluded from your population, your study population. And my question to you is, could that have introduced some sort of a bias?
For the selection of the women,
yeah,
we excluded the pregnancy-related VTE because we want just to observe the risk associated to the oral contraceptive. Women who had a previous pregnancy wouldn't be on oral contraceptive. So this is why we excluded those women, because we want to evaluate the exposure only to the oral contraceptive for the event. So I don't think that that exclusion criteria would affect in particularly the results in this case.
If we would suppose that those with pregnancies would more often be the women that would be older than 30, because they would be more often having had pregnancies.
Yes.
So you would have got all these patients who cannot get a thrombosis anymore from your case mix. So your case mix for the older persons would really be not as severe as the case mix of the younger person. So maybe there is no difference. Maybe it's just all bias.
Well, this could be true if we observe different number of women under or over 30 years. But in these studies, we have similar numbers for both groups. So the women, yes, for sure, they over 30 years could have more pregnancy, and but we analyzed similar numbers between the two groups, and so I think that this stratification analysis could lead us to evaluate the different risk before and after, and possibly after the 30 years, the risk increase for other reason.
I think the increasing risk, I'm totally agreeing. And if you look at table 3, and there you make a distinction between first use and multiple use. And if you look at the women under 30, as opposed to the women over 30, then you see that in the multiple users, the difference is really getting closer to each other. So they are not as different anymore as the first time users. So maybe keeping in mind that you have, in the first-time users, you have this higher risk population of women that had pregnancy, so that might have used before. Maybe this will really show you a little bit of this bias.
Yes, in the multiple over 30 years, I think, yes, I agree with you, because if a woman had already a thrombotic event, maybe they don't take oral contraceptive anymore. So in the multiple users after 30 years, we exclude those women.
Thank you.
Thank you. Ms. Abbattista, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return.
Thank you.
Ms. Abbattista, the degree committee here present online has assessed the quality of your thesis and your defense. In view of its positive verdict and taking into account the previous qualifications, the degree committee has decided to grant you the degree of doctor. Professor ten Kate, your supervisor, is authorized to confer upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Thank you, Mr. Pro-Rector. And we start with a promise that you have to make. Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise.
Thank you very much. By the authority vested in us by law and in conformity with the decision of the committee here present online, I hereby confer upon you, Maria Abbattista, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, you will soon receive the real degree certificate signed by the rector, the secretary, and the supervisor, affixed with the official seal of the university, as shown now by the beadle. Congratulations, Dr. Abbattista. I'm really proud that you did this, that you accomplished this. You defended your thesis very well. Once again, I'm pleased and honored to be part of this supervisory team. But for the remainder of the laudatio, I'm happy to give the word first to your co-promoter, Dr. Martinelli.
Thank you.
Can you unmute, please?
Yes, sorry. Well, I started before what I had to do now. Sorry for the mistake. Anyhow, in these years, I saw that spent with Maria, I saw how Maria improved her skillness, attending several courses and also studying a lot by herself and catching every medical sense of our group. And I can tell you that when Maria comes with some data, you can be sure that they are valid. Her PhD thesis, I think that witnesses her continuous dedication and the seriousness of her working method. I would define Maria stubborn as a mule, extremely determined in understanding, proceeding, and reaching the final result in research. And then what Maria is plenty of, I know her quite well, is good sense, critical sensibility, and desire of in-depth analysis of the things and problems. The same method is applied by Maria in the kitchen. And this makes Maria one of the best cooks all over the world. She comes from Apulia, the region representing the heel of our Italian boot, with a historical excellent art of cooking, and the application of her methodology in that setting, plus a bit of fantasy not applicable in research, gives excellent results. To conclude, then I can leave the speech to Professor Manucci. It has been a true pleasure and an added value to have Maria on board. She's a nice example of the skill and dedication of our young researchers.
Thank you, Professor Manucci. Can you please unmute? If not, Professor Martinelli, anything to add that might have been said by Professor Manucci?
Professor Manucci was really determined in pushing Maria to do this PhD thesis. And of course, we are very grateful to Maastricht University, to all of you, and in particular to Professor Tenkate, to accept to give Maria this great opportunity that to me is totally deserved, because she really gave a great contribution to our research, and I don't want to seem unmodest, but I find that this is a very nice PhD thesis with a very nice connection regarding women health issues. So I think that she was not only a co-worker, but very often very propositive and really a good researcher, really active in doing this work.
Thank you. Dr. Abbattista, also on behalf of the Board of Deans and the entire scientific community at Maastricht University, I congratulate you with the honor you have acquired, and I hope that you will remain to be steady as a mule in your future research. I hereby declare this ceremony to be ended. We will remain in the room for the members of the committee to have the opportunity to congratulate you as well. But I close the official part of this ceremony. Thank you all.
Thank you.
Thank you.